Welcome everyone to Mary Washington Healthcare's virtual EMS night out for June. We appreciate you joining us. Please take a moment to read the instructions for tonight. Very important that your name is visible on your login so that I can identify who you are for proper CE. And then please keep your microphones muted until the end. We will open it up for questions. You can also use the chat feature in Zoom if needed at any time during the session. We will be monitoring that as well. And very excited to be talking about dementia this evening with a group from VCU. And the title of tonight's lecture is Becoming Dementia-Capable, an EMS Provider Call to Action. So very excited about this lecture. Before we begin, I did want to introduce and recognize Kelsey Rideout. She's the Performance Improvement Specialist with the Rappahannock Region Office of EMS. And she's going to share a little bit of information with us as well before we start the lecture. So turning it over to you, Kelsey.
Thanks, Tina. Good evening, everyone. I just wanted to take a couple of minutes to talk about our COPE program, which stands for Community Outreach and Patient Engagement. This program used to be called MIHCP, which stood for Mobile Integrated Healthcare and Community Paramedicine, but it's really evolved over the last four and a half-ish years that we've been doing this. So it's a better resource now for patients of any age, not just the geriatric population that we're going to hear about tonight. So on the community outreach side of this program, we attend an event called The Table, which is coordinated by St. George's Church. It takes place downtown in Market Square, and we go every other Tuesday, although it does happen every Tuesday, but we attend 2 Tuesdays a month, and it's from 12 to 1:30. And it's an event that allows anyone with food insecurity to come in and have access to free, fresh produce and other social and health resources. So sometimes there's a table for folks to be checking blood pressures. Sometimes there's dietary nutrition information. Other times there's diabetes management, just some examples. The vendors change week to week. And then our table offers information on emergency preparedness, COVID-19 resources, and seasonal topics, like, for example, heat and cold emergencies. So it allows us to interface with about 100 to 125 people every time we go to this event. And then on the patient engagement side, REMS sponsors a website called Access Me Care, which is hosted by Hudia. And this is where people in our region can get connected to social or other healthcare needs that they may have. So you can go to the website and search for services, like perhaps someone needs a dentist or behavioral health services. And the website will give you options for what's locally available within our region and that has been vetted. So it can be used by either patients or EMS providers if you're trying to assist a patient. So it's just another tool that we have to get resources out to our community and our region. So if you'd like more information about any of those, either of those, I can get that to you. I'll put my email in the chat box and feel free to reach out. And now I'd like to turn it over to our speaker tonight. Her name is Kimberly Davis, and she is an assistant clinical professor with the School of Nursing at VCU.
Hello, thank you very much. I want to welcome you to the overview and introduction of Becoming Dementia-Capable, EMS Provider Call to Action. So the focus of this presentation is on the challenges of living with dementia from both the patient and caregiver perspectives, including disease progression management, communication skills, of course, and the caregiver, and community resources. The content aligns with goals set forth in the Dementia State Plan, which is called Building a Dementia-Capable Virginia, and really looks at incorporating a public health approach to mitigate the impact of dementia. As frontline workers, EMS providers are uniquely poised to help with the goals set forth in the dementia state plan, such as early identification for older adults who would benefit from referral and early treatment, thereby reducing disease and disability. All right. So the project is supported by the Health Resources and Services Administration under the Geriatrics Workforce Enhancement Program grant to the Virginia Geriatric Education Center Consortium. I'm Kimberly Davis, Clinical Assistant Professor at VCU. I am a registered nurse. I have clinical experience taking care of older adults living with dementia in acute care settings and also in long-term care settings. I have with me here today Dr. Kathy Tompkins and Dr. Pamela Teester, who are also core faculty of the Virginia Geriatric Education Center. So I'm going to let them introduce themselves and share their areas of expertise. Start with Kathy Tompkins. Go ahead.
Good evening, everyone. I'm Kathy Tompkins, and I am a professor in the social work department in the College of Health and Human Services at George Mason University. So I've been here since 2003, and I am a gerontologist, and my area of focus is on dementia caregiving and as well as non-pharmacological interventions for people with dementia. Nice to see you.
So hi, I'm Pam Teester. I'm a professor and the director of the Center for Gerontology at Virginia Tech. So like Kathy, I'm a gerontologist. The areas of work I have done a lot of research in have to do with elder mistreatment, have to do with surrogate decision-making. That would be powers of attorney and guardianship and family members who do that sort of thing. And then another area that I have as an area of expertise is clinical ethics.
And thank you both for joining the call and for adding in your expertise here during this presentation. Okay, so a quick disclaimer, I'll let you read through that. We include that for your reference. Okay, and so for the objectives. So within the context of Virginia's dementia-capable plan, we'll explore the objectives that you see here. I want to really go into some detail about the signs and symptoms of dementia in older adults and what's going on behind the behaviors that we see. Explore the role of EMS providers within this context, caring for older adults living with dementia, including communication techniques and trust building strategies. We also will share helpful resources that you can use to build your skills and confidence well beyond this presentation. There are about 6 million people in the US that live with dementia, and the majority of those live in the community, not in an institutional setting. That number is expected to more than double over the next less than 3 decades. Okay, so this is a growing issue. Behavioral symptoms such as memory loss, confusion, aggression, and agitation, plus the chronic medical issues like diabetes, hypertension, heart failure, together those things bring people into contact with EMS providers. So that's the context for our discussion. Quick polling question. How confident are you caring for someone who is living with dementia? Somewhat confident, we see the majority. Okay. And then actually quite a number not at all confident. So that's really helpful information to know. Okay. So I believe this presentation will be helpful to the majority of you. Very few of you said that you were very confident. So let's a little background here on just what is dementia, a very basic. And I'm going to kind of level you here where we're going to start kind of broadly, and I'm going to slowly bring you into a more detailed view over the next several slides. So dementia is not a normal part of aging. According to the Alzheimer's Association, Alzheimer's disease is a growing public health crisis in Virginia, and without an effective treatment or cure, the impact of Alzheimer's will continue to rise. And the numbers in Virginia specifically are only escalating. 150,000 people aged 65 and older live with Alzheimer's in Virginia. And the number of Virginians living with dementia is forecast to rise to 190,000 by the year 2025, according to the Dementia State Plan. Now, I want to emphasize there's early onset dementia too, so we would not rule out dementia based on age. So it's important. I know I keep saying older adults because that's usually the case, but we also see 8.9% of people aged 45 and older having subjective cognitive decline as well. And so this isn't just a disease or a problem with older adults. 349,000 family caregivers bear the burden of the disease in Virginia. There are high costs associated with this. It's estimated that 521 million hours of unpaid care are provided by caregivers. And these numbers show that a public health approach is necessary to lessen the burden and enhance the quality of life for those living with cognitive impairment. All right, so you've kind of heard me saying this, a person living with dementia, rather than saying someone who has dementia. It's recommended that we have dementia-friendly terminology. And so you'll hear me saying someone living with dementia to try to promote that. Dementia capability means being skilled in identifying people with possible dementia and working effectively with them and their care partners or caregivers through the stages of their disease. So dementia describes, just in general, several disorders that cause significant decline in one or more areas of cognitive functioning, severe enough to result in functional decline. So dementia is really the umbrella term for several diseases that include Alzheimer's disease. And Alzheimer's disease is the most common of the dementias. It accounts for 60 to 80% of cases. So you hear me referring to Alzheimer's disease quite a bit throughout the talk today. But it's usually characterized by a significant decline in one or more cognitive domains, language, memory, or executive functioning. So again, it's not a normal part of aging, and this is different from normal cognitive lapses. So examples of normal aging would be like mild decline in memory, requiring more effort and time to recall new information, but the decline does not impair functioning. New learning might be slower, but it still occurs and is usually well compensated with lists, calendars, other memory supports. But dementia is progressive and disabling. Clinically, it's characterized by a gradual onset and progressive decline in cognitive function, and motor and sensory functions are spared until late stages. So it's not obvious all the time when you see someone who has dementia. You know, they're not just going to have, you know, a cast on their arm, and so you know something's wrong. It's a disease that affects how their brain interprets the world around them. So it's really important to be skilled in identifying the disease. Living with Alzheimer's disease by age, at age 65, 1 in 20 people are living with Alzheimer's disease. At age 85, 1 in 3. Dementia affects 200,000 people under 65 as well. So not just a disease of older adults. And the economic impact is pretty huge. $818 billion are spent annually for direct costs of medical and social care and informal care. And there's emotional impact, the direct toll on patients. Nearly half of caregivers suffer psychological distress, especially depression, and half have more physical health issues as well. Okay, so going a little bit deeper here, symptoms of dementia can vary widely, but what we look for is a significant impairment of 2 or more of the features that are listed here on the slide. So with memory, you might see this manifested as confusion and unkempt appearance. You may see agitation and irritability, especially related to an inability to communicate their needs. You might see paranoid thoughts, wandering. The Alzheimer's Association estimates 6 out of 10 people with dementia will wander at least one time. You might see impaired thinking and reasoning, unable to follow time. They tend to lose the peripheral vision, and vision's affected. Sounds become distorted and confusing. So we're going to go a little deeper into all of those things in a moment, but they're not perceiving the environment the same way that they had prior to the disease. Some non-modifiable risk factors would be age is the strongest predictor. Family history as well. Parents or siblings with dementia is also a very strong risk factor. There's some genetic associations, also a history of mild cognitive impairment or Down syndrome as well. Potentially modifiable risk factors could include cardiovascular risk factors like hypertension, high cholesterol, someone who's a smoker. Those are potentially modifiable. But even lifestyle also is something to keep an eye out, like poor social and cognitive engagement, Even low educational attainment is considered a potentially modifiable risk factor. History of depression, and another one is someone who's had a traumatic brain injury in the past could also be considered having a risk factor. So we would consider things, across the lifespan, there may be things that we could modify, in advance. Okay, another polling question. Symptoms of dementia vary widely and are progressive, which I've just said. Signs and symptoms of dementia could include which of the following. Now, this is a select all that apply. So which of these answers, and you can select more, or you should select more than one. Yes, I'm looking for impaired visual perception. Looking for difficulty focusing and paying attention. Some lack of judgment. The one that is not correct is altered level of consciousness. So that is not correct. We're going to talk more about that in a few slides. And significant memory impairment is also a correct answer. So I was looking for A, B, C, and E there. Okay, good. Oh, I'm going too fast here. Okay. All right, let's go a little bit deeper into what's happening in the brain. Okay, so it's important to understand the changes that are happening in the brain when someone is living with dementia. So don't just focus on the loss of memory, although that's probably the first obvious sign that you're seeing. It's so much more than that. In a couple of minutes, we're going to show you a short clip that's taken from Teepa Snow. She has a whole website. She's an expert in training on care of dementia, leading educator. And I've learned so much from attending her workshops, and I'm going to share some things I learned from her, and also things I've learned just from working myself working with those living with dementia and related cognitive disorders. But she's an occupational therapist. She has 40 years of clinical practice, and a very good resource I wanted to definitely let you know about if you hadn't heard of her before. Okay, so if you have a good understanding of what's happening in the brain and what's going on as the disease progresses, it can really help you frame how you then communicate with that individual. So I have a picture here on the slide because it's estimated that people living with dementia may actually have a brain size that's a third of the original size as they go into the advanced dementia stage. So you see the full size of a healthy brain on the left side, and then what somebody's brain may actually look like with an atrophied effect as the dementia progresses. So it's a really good visual to keep in mind when you're trying to come to terms with some of the behaviors that you're seeing. The area of the brain that seems to be most preserved, and with most dementias seems to be the last to go, are the core functions, such as elimination, thirst, the wake, sleep, hunger, temperature control, regulation, impulses, and emotion. And the ability to recognize threats, the flight or fight response, is generally the last to go. But what we do see as initial areas of damage in the brain is the loss of impulse control. So we all have this warning system, right? That helps us decide not to do something that could be harmful to us or allows us the ability to delay gratification. But when the cortex is damaged, we see people having trouble with decision making. The frontal and prefrontal lobes helps us with perspective. It helps us with some empathy. So in someone living with dementia, you might see impulsivity. They might make decisions that don't make sense. Then they may have trouble making decisions. They might not be able to see things from anyone else's point of view but their own. And sensory processing is also impacted. Damage in these areas helps to explain some of the behaviors that we end up seeing. And we're going to talk a little more about sensory processing on the next slide. But definitely possible that somebody living with dementia may still be doing pretty well with things that they learned and retained from the past. But when we're trying to teach them something new, they can't retain it. And so they might be able to replicate something you're trying to teach them in the moment, but they couldn't remember it 10 minutes later. And so they're going to repeat, and they're going to ask you to repeat. And so there may be some long-term memory that is intact, but not short-term memory. Okay, So let's drill down a bit further into what's going on in the brain. This is the slide I'm going to spend the most time on, and then the rest of it we'll spend probably a couple of minutes per slide. So behaviors may be challenging, but they're also an attempt to communicate with you. So let's look at behaviors within the context of changes in the brain. Impulsive, all right? So maybe as EMS providers, you're responding to a call out in the community, you're being asked to stop someone's inappropriate behavior to help respond to something going on, whatever that might be. And so there is value in reframing what exactly is going on. So what exactly is the behavior? As you're identifying that this is someone with cognitive impairment, possibly dementia, stop to reevaluate the situation. What are they trying to communicate to you? What are they trying to express? Because maybe their language isn't intact anymore. Maybe they're really needing to do something basic like go to the bathroom and they're not able to say that. And so you're just seeing this increased agitation. And so it might be that we're perceiving their behavior. It's not in alignment with what they're trying to tell us. So we try to see the situation from their point of view, not just our own. How are they perceiving their environment that could be different from how I'm perceiving it? There is some kind of unmet need. All right, so consider visual changes, such as I mentioned, the peripheral vision is lost, and then only having central vision, like tunnel vision. So if you come up behind them and you touch their arm, you're going to scare them to death because they don't see you coming. So understanding that you have to be really direct in the way you place yourself so that they don't feel threatened. They might need to look at you straight ahead and not from the side. So think about how they're perceiving you, knowing that their vision is changing. They also might experience double vision or loss of depth perception. So sometimes we see behaviors that we call picking behaviors. They're actually like picking at patterns or objects, and they might just be on paper or on a painting. And it doesn't make sense to us. What are they doing? And it looks like they're trying to pick something up. And it could be it's a picture of a piece of fruit, and they're trying to pick the fruit up because to them that perception is lost, and they think it's real, a real object. So what about hearing? It could be that hearing is distorted and they're not hearing things the same way. And so also in this context, we think about things like their vocabulary, and are they still able to communicate their needs verbally, or are they unable to actually talk? Sometimes what I hear is kind of like a gibberish sound that you're hearing, and the words it doesn't string together and make sense. So you can imagine how frustrating this would be for someone who has some thoughts, has needs, just can't communicate that to you. So again, we're putting ourselves in their position. Interestingly, people living with dementia seem to retain their ability to have a conversation. Think of it like a volleyball. So you say something to them, they can lob it back. So a rhythm of speech is actually possibly retained. So you might in one instance be able to sort of feel like you're having a conversation with them because there's this kind of automatic process that's happening, when in actuality, they're not really understanding exactly what the conversation means. They're going to ask you to repeat the same thing 10 minutes later. And so you could engage in some kind of a back and forth that's more about the fact that they've retained the ability to have this automatic response to simple questions or simple statements. But honestly, it can be comforting to them because it feels natural. It feels familiar to them. So even if you're not completely getting your point across, it can still be calming, is what I found at least. Interestingly, this may also be true with music and the ability to sing songs and have some kind of rhythm to music that can be retained. And that can be comforting to them when they're able to dance and clap and sing. Prayers or poetry can be retained as well. These things that can be kind of automatic and pulled from long-term memory. So they might even be drawing from that long-term memory. Maybe a song's familiar to them from when they were in their 20s. That might actually be helpful and calming to them. I know when I worked and helped out in adult daycare centers, we would just pull all the old songs that were familiar to them, and you could change the mood of the room in an instant. It was really nice. Actually, I wanted Kathy Tompkins to say a word about this because she's doing quite a lot of work around music and memory. If you just maybe talk about your work a little bit.
Sure. So we just finished up a study, a statewide study where we were looking at, so there's a national program called the Music and Memory Program. You could Google that and see what it's all about. But what we were doing, and researchers across the country are doing similar work as well, is trying to put some science behind what Kim was just talking about in terms of the personalized music. So really the music that folks living with dementia enjoyed in their late teens, early 20s. So that personalized music, we're looking at how that music can stimulate memories, can stimulate language, just like we were just talking about as well. So somebody that's not able to, answer questions that you're having, oftentimes, even if you have your phone and, you can kind of guess about the age, this isn't so much person-centered music, but this is helpful too. Like if, you think there may be the 40s, music of the 40s or the 30s or the 50s was something they might enjoy, putting that music on your phone may help stimulate language as well as calm down anxiety or other types of behavior that might be disruptive to you doing your work with this particular person. So we've just finished up some work in long-term care facilities, and we are in the middle. We're actually starting year 2 of a work with the Music and Memory Program with caregivers who are caring with people with dementia at home. We're really finding some very interesting results in terms of what that personalized music can do for people with dementia in terms of the stimulation and reducing anxiety and other behaviors, but also in terms of kind of calming down the stress of the family caregivers.
Awesome. Thank you so much for sharing that work. And certainly we encourage you to check it out, check out that website and have a look yourself. People with dementia tend to keep those forbidden words as well. And so they might be saying inappropriate things that are not considered socially acceptable. And maybe they would have never talked like this in the past. Sometimes we see their families kind of horrified that they're swearing and they never used to swear, and they might exhibit racial slurs or exhibit sex talk. And honestly, we just need to let it go. It's part of the dementia. Don't dwell on it. Just move on. Don't be offended. This is just a piece of the brain that tends to be retained. And then there's this idea of curiosity that's retained, but they're not as aware of safety that's involved. So they might not be aware that the temperature of the water is too hot. They're not aware that they need to be careful to check that to not be burned. They're not recognizing danger like they had. So things like making sure there's temperature control on water heaters are really important because the sense of knowing how to predict danger is not going to be as intact. If we have time for it at the end, I have several slides that talk about home safety, and those are recommendations more specifically about that and how you can make sure their environment is safe. And for you all as EMS providers, it's being aware that as you have that unique position to be in someone's home and notice some of those things, and even just take a moment to talk to the family and say, hey, you really should think about, with someone, your loved one having dementia, that there's some safety concerns here. One last thing on this slide, smells. They might not realize that they've soiled themselves, and there might be a strong odor from feces and urine, and they're just not aware of it. They might smell something that smells really good, and so they're paying attention to that. Or they might not pay attention to smell at all, or even think about safety like food that has gone spoiled. So we would know to throw it away. They might just not be as aware they need to do that because of some of these sensory changes. All right, so I wanted to briefly talk to you about the 5 goals that are listed in the Dementia State Plan. And you all are right in the middle of these goals. So it's very applicable to you as this audience. We already talked about dementia capability and the dementia friendly terms like person living with dementia. But so goal 1 is coordinating quality dementia services in the Commonwealth to ensure dementia capability through having a dementia services coordinator and state funded initiatives. Goal 2 is using dementia related data to improve public health outcomes. For example, measuring the impact of dementia and public health efforts. Goal 3 is increasing awareness and creating dementia specific training such as this. That's to the medical team, to first responders, and also the caregivers and the families. Providing access to quality coordinated care for individuals living with dementia in the most integrated setting. So by providing statewide services and support. And then lastly, expanding resources for dementia-specific translational research and evidence-based practices, like we heard has been on Dr. Pam Teester's work. And so another example is supporting Alzheimer's and related disease research award funds. So that's one of the goals listed in the state plan. So we're going to go into these goals of involving EMS providers in more detail on the next slides. But first, some key points. EMS personnel are frequently the first to respond to people with dementia, but my understanding is there's very little to no dementia-specific training that's in your core curriculum. And adding to this complexity is people with dementia frequently do not report they have a dementia diagnosis or their medications to EMS providers. I'm sorry, I did forget to show that first video. I'm going to pause here because there's a really good 1-minute video that explains some of the things I was just talking about. Apologize for that.
People living with dementia, the dementia is attacked asymmetrically, normally on the left more strongly than the right. So something we want to remember is, try this with me, language on the left, rhythm on the right. You lose on the left and retain on the right. So we have rhythm on the right, which is music, poetry, Bible verses. People even can play the piano. Language, skills, word finding, nouns, and things like that. Those are lost first. So the positive approach is to give them the visual, then the verbal, and then touch. So I'm going to stop at 6 feet out, wave, approach. So if she receives me, she will stick her hand out. So I'm going to go into hand under hand.
Okay, great. Thank you so much for showing that short video. This is from Teepa Snow's website, and she certainly has extensive training and stuff that you would need to pay for, but there's a whole lot on her website. And I wanted to show you that as an example. There's a whole lot on her website that is free. You know, that's like a little vignettes that show you what she's really talking about. So I'm going to just back up, I think, one here. Okay. All right. So I was saying that adding to the complexity, people don't usually report they have a dementia diagnosis to EMS, or even what medications they are that might clue you in that there's something going on. So sometimes you're kind of flying blind, which is why we wanted to explain some of the symptoms and kind of help you understand some of these behaviors. Ideally, increasing skills of understanding of how we respond to people with cognitive impairment could lead to decreased ED visits and hospitalizations, because knowing that someone has dementia can affect admission decisions. So it's important to have some knowledge about this. Okay, another quick poll question. There are several differentiating characteristics between what we call the 3 Ds: delirium, depression, and dementia. So I'm just asking you to select one answer. Which of the following characteristics might indicate a person who's having altered cognitive status is experiencing delirium? So which one shows delirium? All right, we got a good majority correct response on this. So yes, the acute onset fluctuating course is the one that we look for with delirium. So I want to talk about this a little bit more depth for you. So these are some of the differentiating characteristics I've listed here on the slide, just to help you understand the difference between, again, what we call the 3 Ds, which can all appear to reflect some level of cognitive impairment, depending how they're presenting. And it can be hard at first glance to tell the difference. So we want to pay close attention to any concerns that are expressed by the person or their family or caregivers in the interprofessional team. And you should be aware that also people can be symptomatic of all three. So it can be hard sometimes to tease out what's really going on. But it's really important to rule out delirium. I've listed some of these characteristics on the slide for you here. It's evident when there are the first two. There's the acute onset, so it comes on pretty quickly, fluctuating course, and they are exhibiting an inattention, plus either disorganized thinking or even an altered level of consciousness. Delirium is presumed to be reversible, treatable, but it can have a high mortality rate if it's left untreated. So it's really important that we treat the cause pretty quickly. We also want to differentiate whether what we're seeing is depression. Is this a depressed mood, loss of interest, versus some signs and symptoms of dementia like we've already been discussing? Are we seeing an impact on memory and functional status? Develops more over time than this acute onset. So it's important to again pay attention to concerns that are expressed by the caregivers about what's been going on over the past months, versus just days. And of course, if you suspect any of that, you would refer out, to their primary care provider, make sure they have follow-up. It's very important to correctly identify cognitive impairment, as we just mentioned on the previous slide. Also knowing who's at risk, whether they have those modifiable risk factors or not. So a big challenge here is the de-escalation. So we might have someone who's agitated, maybe even aggressive, and that's where you're going to come into the picture in most cases, right? So you're trying to respond to the situation, knowing if you have that knowledge that this is dementia related, then what could you do? An empathic response is necessary, and portraying yourself as non-challenging. So meet them where they are in their reality, trying to build trust and acknowledging their emotions. So not, no judgment. So an example might be maybe there's an older adult living with dementia. Maybe she's currently living with her daughter and she's demanding, she take me home. And so to try to deal with a behavior where maybe you can't meet that need, maybe ask where the home is, use the moment to talk about her home, distract her with something she enjoys. So using some distraction. But the key takeaway there is find a trigger word. So what word is kind of evoking that positive response? And you have to kind of have that bag of tricks and pull out what's working for them, abandon it if it's not, move on to something else. But here the trigger word would be home. Engage her in the memory while diffusing and intensifying the situation. Maybe it's grandchildren, pick that, but you're trying to, again, you're diffusing a situation, but trying to kind of divert their attention without escalating. Another thing that you'll see in the literature is called therapeutic fibbing. So that's a technique that relies on the use of mild deception or distraction to diffuse a situation of anxiety, sadness, or danger. So you can reduce agitation or promote cooperation in a crisis situation. It's considered a distraction technique. It's a non-challenging approach. You're not trying to correct their misconception, rather you're attempting to reduce their sadness or anxiety and lead them away from a potential danger. For example, there might be a fire in the home, someone living with dementia saying, I'm not leaving. It's really important, at that point, that it's for life-saving measure to say, use therapeutic fibbing, maybe say, I'm taking you to your daughter. If that's sort of that trigger word, oh, okay, I'm taking me to your, and certainly you would if you were able to, but something that will trigger, be the trigger word to then help de-escalate the situation and help lead them to safety. But another challenge you all have is the inherent brevity of EMS calls. You have such a limited amount of time to determine what's going on. You also might have limitations of resources, although hopefully the ones we provide you today will help. And then also this interagency communication and lack of interoperability can be a problem too. If you don't have access to everyone's medical records, you don't always know what's going on. So just trying to acknowledge that, yes, there are some inherent challenges here. These are examples of when a first responder might be called, and then we'll have to quickly determine underlying causes to help decide how to act and redirect and intervene. So just a few more examples here. Wandering. So maybe you'll be, out on a call for someone who's missing. There's no coherent path. They try to hide. They might not respond when they're called. Swift actions obviously needed when we have a report of someone missing who has a dementia. Hopefully we can use alert systems. Hopefully we're using voluntary registries, electronic tracking if available. And if your community has Senior Alert, Project Lifesaver, and other wandering prevention and response tools, that can really help if you could plan ahead and help families who don't have that in place to get it in place ahead, because we know that they're likely to wander at some point. Driving, they might appear confused or intoxicated. They might drive erratically. They don't obey signs. They should be cited, not just given a warning. There needs to be a paper trail. So it might feel nice to say, oh, well, we understand there's some cognitive impairment, but really that's not going to be helpful in the long term. There really needs to be a paper trail that's going to help with diagnosis and follow-up and intervention. Abuse and neglect. There's a presence of self-neglect in 14 and 19% of people living with dementia. There's a high risk of abuse by caregivers, and EMS are often the first to identify that there's abuse going on, because you, again, are uniquely poised going into people's homes and seeing some things that that healthcare professionals and clinics wouldn't see. So of course, you would report and refer to social services, hopefully also to primary care providers for follow-up. Shoplifting, here's a socially inappropriate behavior, right? We had discussed that this might happen. They forget to pay. There's no intent. There's confusion surrounding the event. They honestly don't understand. And so there'd be a need to try to also use some of your skill in de-escalation there. Disaster response. A lot of confusion can happen during disaster response. Any change in routine can put someone with cognitive impairment at increased risk of injury. So you're trying to redirect, de-escalate, link them to their caregiver or family, be very concise with direction, try to keep it simple and straightforward. Okay, another question. So which of the following is an accurate statement about the role of EMS providers in caring for older adults who are living with dementia? So this is just a multiple choice. You'll select one answer here. So the role of EMS providers. Yes, all right. So we have all of the above is what we're looking for here. Great. Yes. So again, and it may be that you're telling the family, hey, you really need to get your loved one in to be seen here. You can de-escalate a situation and say they really need follow-up. So that's something that you can be part of. So the goals for the EMS provider are to identify risk factors, as we've discussed, and to promote early diagnosis through these referrals. So we're looking to improve their quality of life, timely use of available resources, and hopefully have potential cost savings as well. So promoting early implementation of active management through referrals and connecting them to resources. We have things like community advocates, legal organizations to get involved. You want to make sure that older adults living with suspected dementia, as well as their caregivers, are supported. And that's, again, something that EMS providers are uniquely poised to be able to do. So if you suspect someone has delirium, dementia, or depression, they should be referred to follow-up medical care, of course. So primary care providers are our first go-tos, but then specialist referrals out to geriatric psychiatry, neuropsychologists, there's memory disorder clinics, depending on what primary care providers might find on screens and assessments. And so then we can get other people involved on the interprofessional team, like social workers, physical therapists, occupational therapists, speech therapists, nurses, pharmacists, and there's others. So we really want to surround that person and their family and caregivers with resources to try to get that expertise to them. An attorney could be used for will conservatorship. Local area agencies on aging are a great place to start to really try to connect as well. REACH is a mnemonic that might be helpful to you. So let's go through this quickly. Risk perception is, so when you're responding to a call, you're considering what's the overall risk to self, to others? Is it low? Is it high? So you might need to do some reframing to best understand what's going on when we've identified someone with cognitive impairment and you're trying to de-escalate the situation. You're thinking about risk, trying to reframe that. And so they're, again, you might end up doing some kind of therapeutic fibbing and to try to help them move out of a dangerous situation if you assess the risk is high. You also want to establish trust. So again, think about their perception and potential vision loss. You want to make some eye contact, get down on their level, introduce yourself, offer reassurance, hey, I'm here to help you. Try to avoid coming right up behind them and startling them as much as possible, like you saw in that short video. Assessing their needs, so even long-term, are there some community needs? There's a need for, referrals that you could make, connecting them to community resources. Promoting a calm environment, so monitoring for distractions if you're able to. Separating them from something that might be causing increased agitation to try to calm them down and promote an environment where there's not so much stimuli. They can be overstimulated. So try to minimize unwanted distractions. Think about how they might be hearing or seeing their environment, even smelling, because all those sensory changes. So use your knowledge of how the brain is changing to try to think about their perception. And then healthy partnerships, of course, clearly stating your role as an EMS provider, is a way to maintain a healthy partnership, of course, between you and community members. Okay, this is our last polling question. Verbal and nonverbal communication are very important when working with a person who's living with dementia. So which of the following are effective management techniques when working with someone who has cognitive impairment? So a little knowledge check here about what we were just talking about. This is a select all that applies. So you're going to be selecting more than one answer here. So some verbal and nonverbal communication techniques. So we were looking for A, don't approach from behind, C, don't argue or correct, and E, don't touch without asking. So excellent job, very good. Okay. All right, so another technique we see in the literature is the talk tactic. Remember, it can take up to 90 seconds for them to process what is being said to them. So talking very quickly, using long explanations is not going to be helpful. So be concise, speak slowly, use short, simple statements, rephrase instead of just repeating, be positive, meet them where they're at. We're not trying to challenge their reality. That can cause a lot of frustration. Build trust with eye contact, go at eye level, introduce yourself, let them know who you are, what you're doing. Remember those visual changes as well. We already talked about some referrals, so I'm going to skip over that. And then talk briefly about the home safety assessment. We have a few more minutes here. I just feel like EMS providers have an advantage most of the healthcare team does not have, because you can see the home environment, even if it's just briefly. And there's so many things you can pick up in just a few moments of being there. Recent data from the National Health and Aging Trend Study indicates that more than 30% of people with dementia live alone. And so what do we do? And there's home visitor programs, there's phone check-ins. I mean, the idea of the community paramedics is awesome. So again, you kind of have this unique view. So just wanted to touch on a home safety assessment. It's important to consider context, like do they have chronic conditions? What's going on medically that might have an impact on home safety? So for example, diabetes. What about safe insulin syringe disposal? What about visual changes in neuropathy that might impact their ability to stay safe? Arthritis could result in limitations in mobility. Then family living in the home. So how much about their environment is even in their control if they do live with a family? So are there small children in the home and toys that can be tripping hazards? Maybe there's even a dependency on that older adult for childcare. So And then I think about pets too. There's the emotional attachment, which is great, and it can provide meaning. But what is their ability to care for their pets? You know, do they also present a tripping hazard, for example? So presence or absence of resources like utilities, electricity, running water, appliances. I know you all have seen a lot of things like that. So just a little bit more on home safety assessment. If you identify issues in the lived environment, these are some tips you might want to recommend to the family. So generally, you know, evaluating the environment, they might be at risk in certain areas of the home more than others. So pay really good attention to garages, workrooms, basements, outside areas, thinking about tools, chemicals, cleaning supplies, other items that require supervision, you know, paying attention to odors like spoiled food that they might not be aware of, and to room temperature and water temperature, things like that. Avoiding safety hazards in the kitchen, that's a big one. So put a hidden gas valve or a circuit breaker on the stove so a person with dementia can't turn it on. Consider removing the knobs. Use appliances that have an auto shut off feature. Making sure safety devices are in working order. So having working fire extinguishers, smoke detectors, carbon monoxide detectors, removing or disabling guns or other weapons. They might mistakenly believe that a familiar caregiver is an intruder. And so unfortunately that can be their own children that they don't recognize. Keep walkways well lit, adding extra lights, night lights, trying to reduce disorientation, putting medications in a locked drawer cabinet, removing tripping hazards. And then I do want to say though, we're trying also not to create a home that feels too restrictive. So the home should encourage independence and social interaction in clear areas for activity. So safety, but not that we're trying to make it feel too restrictive. So I really already touched on a lot of this already. I don't think I mentioned laundry room safety though. So cleaning products like detergent and liquid laundry packs and bleach, preventing access to the washer and dryer in some cases, maybe even needing to keep the door locked. So yeah, so it's just, you know, keep those emergency phone numbers nearby, you know, advise the family to keep addresses for local police, fire departments, hospital, poison control helplines, all of those things handy. I did include, there are some tools here and there's a link on your slides. This clinical assessment tool is pretty helpful. The home safety inventory can be individualized based on your clinical assessment of the individual, what you find in the home environment. And if nothing else, it helps to start the conversation with caregivers about the potential need to modify the home environment, increase the supervision, or implement other safety strategies. Additionally, your findings can be used to guide education to the caregivers about any safety concerns that you discovered during a home safety assessment. Sometimes as the disease progresses, the caregiver is not aware of how severe some of the deficits of the person living with dementia really are. So it's really helpful to complete the tool with caregivers, and then it can be revisited when changes are noted in the person who's living with dementia. So I have, I posted some of my references and what, you know, things that I had looked through in preparation, as well, some links to Teepa Snow and the positive approach to care. I also wanted to mention Alzheimer's Navigator as a really helpful tool. You can create a personalized action plan. So these are great resources for you to pass along to families as you see fit. Of course, the area agencies on aging, there's some free first responder training that goes over some of the same things that I was trying to cover here, but you can get a certificate of completion if that's interesting to you to maybe go a little bit deeper into this. The Alzheimer's and Dementia Resource Center is very helpful. Virginia Center on Aging. The Dementia-Capable Virginia is full of resources and so interesting and lots of stuff there. I highly recommend you check that out too, because it's Virginia specific, and you'll find a lot of great tools there. The other one I didn't list was Virginia Navigator, which is also helpful as well for the older adult. I had also meant to put in a link here to a REDCap survey that will take you less than 60 seconds to complete, if you can click on that survey, what it is demographics that we collect, very brief questions, just for our funding agency, because we are supported through HRSA, that, they ask for some information about who we're training. So I just ask you to take 30 seconds or so and complete that survey if you would, for me. And then also we'll take questions.
You all are on the front lines of being able to help people who may have problems, and particularly on my side of the world, if you can spot elder mistreatment, and I mean not that the caregiver is going to jail, I mean helping folks, you're right there to be able to do it. And learning those techniques and stuff will be so helpful.